Thank you, Ira. Thank you very much. Good morning, everyone. It's scary to listen to somebody read your background, resume, CV. My mother always said, beware of people who have long resumes. They have trouble holding a job. Thank you for being here. I'll add my thanks. It's great to see a packed room, to see the interest in this program. I want to thank Blue Cross of Florida for making this possible. I want to say thank you to Dr. Kiss. We prepared for this. A lot of background work went into this to know exactly what we needed to say to you and how we were going to present this material. My job is to set the stage for some really fascinating, important follow-up work the rest of the day in the how-to. You know, what's the granular level of what we need to be doing. Today's Friday, so I'm going to say Monday morning because we're not going to go to work Saturday. Some of you might, but Monday morning when you flip the lights on, what's going to happen differently? How do we move down this journey, this path to a medical home? And I love the title that Blue Cross has put on the workshop, The Journey to This Destination. This is as much about the journey we're all going to take as the spot we want to get to. It's probably more about the journey, and that's a critical fact. It's a critical piece of this. You heard my long resume. The most important thing that I think I can say to you about my background is I'm a family doc. I've done it for 32 years since the beginning of residency and lived through what we're going to go through the rest of the day. And I can absolutely guarantee you at the other end of the tunnel, you're going to be very happy people. That as you take that journey, there are going to be points in time where it's going to feel a little tough. But we'll get you through that, and you'll know that there is a destination at the end when you get that certification and you are recognized as a medical home, that the reason you do it is not to get the plaque on the wall, but that you'll have the triple win that I'm going to refer to a few times in the next few minutes, and you'll hear the rest of the day come up in different forms. And what's the triple win? Everybody in this room, the triple win is patients get better care. They get better outcomes. That's number one. Second, you all are going to love taking care of them in this model. You're going to love it, and we know you're going to love it because we have data from people who've done it already. And the most important piece of that data is people vote with their feet. And the practices that have done this around the country, turnover of staff, physicians, mid-level extenders has disappeared. It has literally fallen off a cliff. People don't leave when they start to take care of patients like in this model. They love it. And the third piece, which is critically important, and we have to say, and you'll see it come up again, it goes with financial success for the practice you work in. It has to go with that, and it does go with that, and we'll show you some data to prove that it does go with that. I want to start with a quote from Darwin, because a lot of us in family medicine look at big stakeholders in healthcare out there, and we think, I can't compete with that. They're bigger, they're stronger, they're more powerful, they're better financed. How in the world am I going to be an important player in this and make my future what I want it to be for my patients? There's your answer. It is the people, all of you in this room, who can adapt to change the best, that will win and be the strongest. Not just survive, but thrive. That's the important thing. The reality is, for most of us in this room, this is the biggest change in healthcare that's happened since the passage of Medicare back in the late 1960s. The system is fundamentally changing in a revolutionary way, and that fundamental change that we're living through right now is that our country has figured out that we can't have a healthcare system that's embedded in volume-based care processes. How much care are we giving? Let's put a code on it, let's submit it to somebody, and let's get paid for the amount of care that we gave. The resource units that were used, developed. That has to change to value. A system based on measuring value, proving we're producing it and giving it to people, comparing what we're doing to a benchmark, and saying we do it better and better and better. And when we do that and prove it, we have to be rewarded for that and not volume. And that's the fundamental thing about this revolutionary inside-out change. It doesn't rely on Tallahassee or Washington, D.C. It relies on us. It's from the practice out, not the top down, when you think of it that way. And that's important to remember. Don't wait for the policymakers to come tell us this is what you're going to be doing. Make the change happen yourself. That's what this is about. That's what medical home is about. So let's start this journey and let's look at how this all sets the stage for what we need to learn in the workshops the rest of the day and the material the rest of the day about what it means we're going to be doing Monday morning. Go back about 2.5 years, and there was a seminal series of lay media articles that came out. You're looking at one of them from the New Yorker in May, the end of May, beginning of June 2009, written by Atul Gawande. That particular article. He's a medical writer. He's trained as a surgeon, works out of Harvard in Boston. But he is one of the leading thinkers on health system change, quality and practice improvement. And he wrote this article about what's broken in America is so well illustrated by looking at 2 different places that he studied in this article. One was McAllen, Texas, way down in the bottom of Texas, the Rio Grande Valley, right by the tip of the Texas-Mexico border. And the other one was Grand Junction, Colorado. And he made a comparison pretty much in the article that healthcare in McAllen, Texas is terrible. It's driven completely by volume, by the business of medicine defining how everybody gets care there. And then maybe after they figure all that out, they'll get to what do we do with the patients and the quality of the care we give. Problem was they never got to that because they constructed their whole system in that part of the Rio Grande Valley based on the business of medicine and the bottom line financially. Grand Junction, Colorado, on the other hand, was cited as what we need to look at because they had a great ratio of primary care doctors to population. They had clinical integration. People were working in care teams. Patients got great outcomes, and the cost of care per patient there was way lower than the national average. So if they could do it, why couldn't our system do it? The reason it became such an important article was the President of the United States said to every member of his administration, you have to read this article. They made copies, gave out reprints, made everybody read it, and as health reform and the Patient Protection Act got developed and ultimately passed by Congress, this was the basis of that. Primary care as the foundation to develop care that's accountable, that measures quality, that measures cost, and puts us right in that equation as being responsible for producing that, measuring it, comparing us to a benchmark, and delivering. Starts here. Interesting little anecdote. In 2 weeks, McAllen, Texas is starting down a pilot project for patient-centered medical home. There will be about, I think we're going to have 6 practices in the project. And it is because they didn't like that. The family docs in that town are very angry. They want to write the next chapter about healthcare in McAllen. And that next chapter is going to be about medical home. They're going to focus on diabetes to prove to the world, because in a lot of what was written, they focused on diabetes, metabolic syndrome, and obesity, and the care that's not happening there. And they want to fix it. They want to prove to the world they're doing better. Stay tuned. It starts in 2 weeks. This is the timeline, left to right, of moving towards accountable health care. So how does this differ from Managed Care 101 from the 1980s and 90s? How does it differ from capitation? Well, it differs because accountability doesn't mean accountable for cost only. It first and foremost means if we're going to be medical homes as the basis of how we build accountable care systems, whether we're in a solo practice, a medium-sized group, or a mega integrated system, it doesn't matter. If the foundation is primary care, our practices, we start with quality being job one, measure it and deliver it, show the world we're doing it, be transparent about that, and that's what's going to lead to cost reduction. Very different than Managed Care 101, which was all about cheap, 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 cheap. Oh, and we'll get to quality after we get to the lowering of the cost. We never got to quality. That's the problem, okay? So, Huey Reinhardt at Princeton, a health economist, I love the way he says this. The problem with the original version of managed care, the reason America hated it, was because when they said to women who had delivered a baby, you got to go home after the first day. You're not going to stay a second day. We're throwing you out of the hospital. You don't have any medical reason to need to stay here any longer. And then he looks at the audience, wherever he's saying this, and he says, that was a bad decision. Whoever made that lost the public. How much Jell-O can she eat on the second day? Let her stay in the hospital. It's okay. There's not, medical need in that setting was not the only operable issue. So when we lost the public and we lost on our side of delivering in a risk environment, capitation, the quality piece, it's taken this long to figure out that as we move from left to right, starting with DRGs, all these alternative payment models, pay for performance, bundled payments, shared savings models, and ultimately back to capitation, that's not the original capitation. When you get to capitation in accountable health care, you've got quality as the first piece of delivering care to a population for which you're being told, here's the money, take care of the population, but when you deliver the quality output, that is going to get enhanced with bonuses all along that path of delivering value. Quality divided by cost. And everybody in this room has to participate to do it. It's not about a person in a white coat marching in, solving the problem, and going on to the next patient. Marcus Welby is my hero. It's my email, MD Welby. Ira was right. I loved what he put up there. But the problem was Marcus Welby only saw one patient a week. He always cured him or her. And next week he had another patient. Well, that would be great if that's the world we lived in, right? That's not the world we live in. We somehow have to figure out how do we take care of this population. And in fact, when the Patient Protection Act, if and when it gets enacted completely, depending on the Supreme Court, whenever health reform, whatever style this revolution ends up taking, again, it's going to happen whether the Supreme Court says yes or no. Don't wait for that. It's happening, inside out. What that's going to mean partly is we're going to be having bigger panels of patients. We're going to have to figure out how to take care of 5,000 people per person in white coat, not 2,000, 2,500. That means teams have to do it. That means everybody in this room who works in a practice, no matter what we do, starts to work up to the level of our license. And we offload from the person in the white coat many of the things right now that you don't need MD after your name to get done, to do. So that reorganizational process is part of what the medical home's about. The culture change to recognizing that we all play a vital role, every one of us, in this practice. And this is the world I lived through in the last 25 years. I'm going to share with you as it plays out in the medical home principles. Why does it matter? When this started about 7 years ago in earnest through the National Demonstration Project that the AAFP subdivision, now called TransferMed, created, there were practices that went through this and the research around what happened and how it happened, that's still ongoing. Literally the largest primary care research project in the history of our system, American system. That's still happening. But everything was measured, looked at, followed, and tracked. And what we learned in the demonstration pilot projects that more or less ended actively a few years ago, but now continue in another thing called the Touchstone project. All the practices that were in the pilots around the country, some here in Florida, continue to be studied and looked at voluntarily. They joined this Touchstone project. We're still measuring these things, but this is why it matters to change and get that triple trifecta win. You, everybody on the staff, enjoys the care more. The physicians enjoy working in this process more. People get home on time. They enjoy the lifestyle more. They enjoy the literal feeling of what it feels like to take care of patients in this setting. We get back to what we went into medicine for in the first place, all of us, to help people. The revenue of the practice goes up. Team-based care actually feels better once you go through the chaos of the first few steps than doing it the way we do it now. Team-based care is fundamentally how humans like to work and do things. But we have to relearn how to do that in healthcare because we've never done team-based care. We've always done fragmented, individualized care. So team-based care is about communication, trust, right? Patient is a member of the care team, putting the patient at the center of that universe, patient-centered medical home. It's about standardization of what we do so that there's not great variability in the process. We have a big problem in America. We have guidelines for a lot of things driven by science and evidence and what we should be doing with each patient. But you know what? We have enormous variability in how we get from the beginning to the end point with each patient. I have a friend who's from Australia, family doc, trained in Australia, practiced in Australia, came to the United States, had to go through training again to get licensed here. So he was my chief resident. And he was amazed, absolutely amazed, every single day as we went through training at watching people in American healthcare. And never, ever did the patient go on a straight line from A to B. Never, ever. Zigzag, zigzag, zigzag. Excursions diagnostically and therapeutically, right? Tremendous variability in the system that has to be taken out. We have great science giving us great evidence on what we should be doing. On the patient side of things, improved satisfaction and patient experience scores is a fundamental piece of the medical home. Proving we're doing it, measuring it, and tracking it over time. David Letterman time. Top 10 reasons patients like the care they get. We're going to do a David Letterman top 10 list for everybody, right? First question I have for you. In that top 10 list of why patients like the care they get right now, they do this every single year. This is studied by Med Group Management Association, this survey. Where do you think patients put that we made the right diagnosis and gave them the right treatment? People in the front are saying lower and lower. How low? It's not number 10 yet, but it's getting there. It's number 8 now. What's 1 through 7? If they put, give me the right diagnosis and give me the right treatment at number 8, what do they put in 1 through 7? Access. Access, access, access. Number 1 always is year in and year out. I call for an appointment. I don't have an emergency. How long does it take before they get me in? Number 2, when I get to the office, how long do I wait before I see the provider? Number 3, how many times does the phone ring before they pick it up? And number 4, 5, and 6, and 7 are all about bedside manner of the doctor, the staff, the facility, and so forth. Access, access, access. If we don't pay attention to that, how can we be patient-centered? So we have something now called patient experience scores. A woman named Dana Safran, who now works at Blue Cross in Massachusetts, started writing about this back in the 1990s, about patient trust in the practice, where does it come from? Patient experience versus patient satisfaction, what's the difference? Patient experience score is all about the total physical and emotional feeling of care that the patient gets. It's got satisfaction inside of it, right? But it's more. And the reason it's so critically important is this. If the patient rates their experience of care as good to excellent, then their adherence to what we ask them to do to get better goes skyrocketing past 90% of everything they need to do, including taking medications and living healthy and engaging with their care, being an active participant, and so forth. If they rate us as fair to good in their experience, it drops to around 50%. Just a dramatic impact on how do they feel about the care, driven by the communication style we have with them, more to come in a few minutes, which builds trust, which is the most important issue. So when we look at this list of what happens with patients in these pilot outcomes and the things that reality brings us in a medical home model, look at all the things there that are driven by an engaged, activated patient in primary care. You can't build an ACO, an accountable care structure, without the medical home is the platform. That's why this is so important today, because the future of American healthcare has got to be about accountability. And you end up with all this drop in cost because you have great quality happening every day in our office sites. Okay? There are a number of great examples around the country of how this plays out. But I want to share with you one that's very local, one that's a safety net of clinics here in Jacksonville, taking care of safety net patients who have no coverage, under coverage, on Medicaid. 11 sites, all patient-centered medical home practices, 11 clinics. And somehow they have figured out a way to deliver this kind of care in the funding environment they're in, and they get great results on patient outcomes, on patient experience scores, on engaging the toughest patients in the community who have limited resources. How in the world do they do it? Well, one of the ways they do it is they figured out that they have to outreach to the community, and they do. They bring the community in twice a month for something they call brown bag lunches. And what's a brown bag lunch? Every patient has to show up with 2 brown bags. One is all their medications, and the other is they bring their own lunch. And in this session they have, every couple of weeks, somebody on the care team talks about a disease state that's prevalent in the community. Diabetes, asthma, COPD. So they have a diabetes brown bag lunch. The team, the care team for diabetes in this setting, in this set of clinics, it's 25 people. How in the world do you have 25 people on a diabetes care team? So we went around the room and we had them come in for lunch. They're in my network of group practices that I'm the medical director of. We had them come in and we said, went around and we said, what do you do, what do you do, what do you do? Look at the list up there, what we learned from the pilots, and I want to share with you one person on that 25-person care team who is the registry expert. She's the person who does the registry function for their population of patients. And if you don't have a registry yet, and you're not familiar with the concept, it's really simple. It's a way to get your arms around a group of patients, a population, around a disease state, push a few buttons if it's electronic, and get a report out and say, how are all my diabetics doing over time with me achieving targets for their risk factors for health? Glucose, blood pressure, lipids, right? The 3 important risk factors. That's like a registry function. She stood up and she said, I'm the registry person for this system of over 100,000 patients. Well, why are you the registry function? I'm the administrative assistant for the clinic director. But I'm also absolutely one of the most knowledgeable experts in this region of the United States on Microsoft Access database. So when the clinic needed to have a registry function, they have an EMR. They went externally and said, let's build it from a good database program. And they did. And she's the one who knows it better than anybody. You don't have to have MD after your name to be an expert at this, right? 3 o'clock in the morning, they routinely get emails from her, everybody on the care team. Because she's so passionate about what she does, she'll run a report, patients' names will pop out, and she'll send an email to the team taking care of that patient saying, you got to do this, this, and this. The patient's not getting to where they need to be. Okay? That's why they have 25 people on a care team. Replicate that with health education and medication adherence monitoring and many of the things we're going to talk about today as we go through the model. The second brown bag that the patient brings in, medicines are in one bag, second one is their food. The people go around the room and they have these brown bag lunches and they say to them, you know, let's talk about nutrition. They see what they bring in for lunch and talk about how to make it better. They do a medicine reconciliation on the first brown bag. What are you taking? Understanding it, raising health literacy with the patient, filling out a piece of paper so they understand what each med is and what they're supposed to do with it. All of this changes the patient engagement and experience dramatically to get these kind of results. And that clinic does such a great job in reducing cost, that system, that they thought they could go to the hospitals in the places where their patients live, in those areas, and say to them, if we do a great job in primary care in our medical home, we're going to keep people out of your emergency room and out of your hospital that would have been admitted because they showed up on death's doorstep in the old way, looking for your ER to be their primary care doctor, and you would have had to admit them, and you wouldn't have gotten paid, either at all or anything near what you needed to break even. You know what I'm talking about, right? Safety net patients, cost shifting. So they sat with the hospitals and they negotiated a formula with them that said, we can identify who we kept out of the ER through better primary care, through what we're doing in all our work, and let's have a shared savings model to fund all this great work, to save the hospitals money by keeping the people from showing up at the ER and needing to be admitted and having high-cost rescue care if they got good primary care medical home at the base. They came up with a formula. 7 years ago, they started this program of shared savings. The formula basically says, for every patient they divert out of the ER in admission, the clinics get 50% of the money back that the hospital would have had to eat because they were underfunded and unfunded patients. Last year, they got a check for $7.5 million on that program. So when you sit here and think about medical home and coupling it to alternative payment methodologies, it's going to happen very fast that your practices will enrich themselves, will have a successful, sustainable model of alternative payments beyond the fee-for-service only payment, which itself gets better, as you will see, in a medical home. You don't have to wait 5 years for the payoff. This is happening quickly. All of it's embedded in something we call the chronic care model. This model comes out of the McCall Institute, a man named Ed Wagner, who proposed this first in front of the U.S. Congress back in the 1990s as what's wrong with healthcare, and what we need to look at is that, and we don't yet, we're still working on it, but we'll get in depth in this in a few minutes. It is fundamentally recognition that our system is currently about rescuing sick people. We build everything around that. And if we have to do one thing when we start, more important than anything else, it's to recognize that more and more every day, we have to take care of people with chronic conditions, multiple chronic conditions in most cases. We still have to be great at rescuing sick people. But the world, and particularly the age demographic in Florida, is dictating that people have multiple chronic things. They don't live with us. You see at the top of that, the patient lives out here in the community, not inside this health system that's gigantic and big and complex and they need help navigating through. And if we don't recognize that when they walk out our door, what happens to them in their community matters more than what we do with the medicines we give them, we're not going to get the job done in getting them good outcomes. How do we know that's true? Well, the AMA has a commission on health disparities, and that commission studies things just like this. What matters more? The medicine that you give patients when they see your practice, making it the right medicine, making the right diagnosis, and giving the right treatment, or what they do in the community they live in terms of eating, exercise, safety, right? All those lifestyle things. And it turns out that what we do is about this big. What happens to them in the community is about that big. And particularly in studies where they found communities where there was a crazy reason historically for a dividing line right down the middle of the community, like a freeway or a railroad track or a mountain. And of course, you know what happens. On one side of the tracks, you have the people with economic resources, higher socioeconomic status, usually white upper middle class. And on the other side of the tracks, ethnic diversity, racial diversity, lower socioeconomic status. And they found those communities. And then they said, well, can we filter that list and say, in the communities that we found, are there some where there's only one group of doctors taking care of everybody? And they found those. So you remove the quality of care issue. And they looked at this and they said, what matters most in the outcomes those patients are getting? Is it the diagnosis, the treatment? Is it money to access care? Is it racial diversity? Is it ethnic diversity? All of those things matter. But what mattered much more than any of that, much more, was when the patient walked out our door after getting care in our practice and went home, Did they walk past 32 places to buy Twinkies and donuts and no place to buy fruits and vegetables? Did they walk past playgrounds that were locked for safety after dark because it was a bad neighborhood? Did they have access to running tracks and bicycle paths? Were there any health clubs to go exercise, or gyms, or YMCAs, and so forth and so on, or not? That mattered more than anything. So if we don't get active about getting out into that community and making a difference, we're in big trouble. All of what happens in healthcare in this model has to be driven by better outcomes, and that happens by having the patient go from a passive recipient of our instructions to an active participant engaged in their care. And that's a new model for us. Because for years what we've tried to do is say to the patient, I'm going to fill your bucket with knowledge, I'm going to tell you everything you need to know, and I'm going to turn you loose and I'll see you in 4 weeks. Go do it. And that doesn't work. That has to be replaced with lighting a fire under them so that the knowledge we give them about their disease state, we raise their health literacy, but we motivate them in a medical home to take active participation. That's when you get some incredible great results. They're a member of the care team. We have a care team working proactively. Every member of the care team in this room gets cross-trained to do more than just one thing. It's not more work, it's different work. And how do we know it works well? Because those practices, now over 30,000 of them doing this around the country, the staff experience scores of what they experience in that care process skyrocket, turnover drops out of sight. That's how we know. We'll get back to this. Here are the principles of medical home that Ira went through again. The principles are straightforward, but living that, what it means to actually enact all these things, that's what this has really got to be about. And that's what your journey today is, and the workshops on how you get NCQA certification and why it's recognition and why it's important is what we're going to go through the rest of the day. Why this model? 3 big reasons. You got to have a framework on which to do the culture change. That's what medical home is about, building that framework. We have to talk a common language. We have to understand each other and be on the same page. And medical home is all about a language of how we need to approach patients to build care that's accountable, care that's measured, care that's giving great outcomes. It also, if we use this medical home conceptual model, it also is about an opportunity for us to go from where we are to where we need to be, to move from volume to value. It's not going to happen overnight. And the reason that's important is you are going to still live in a fee-for-service RB-RVS world, and it doesn't go away the day you got that plaque on the wall from NCQA, and you're going to slowly move into alternative payment methodologies to reward delivering that value. How do you transition? That's what medical home is about. That transition time to not just survive, but thrive so that the patients get great outcomes, do great, you love it, and everything works. This is the transfer med model. I don't know what's going on with the projector, but it's hard to see some of the graphic. But those elements are surrounding this core of continuous healing relationship with a primary care provider, a team at the practice headed by the physician, comprehensive, the whole body, over time, the entire life cycle. And the 8 elements around that are the elements of the medical home that translate nicely into the 9 categories in the scoring system that Carol's going to take you through and the workshops will take you through and understand. But they are about access, all the things that patients care about. It's about the basket of services, the comprehensive nature of what we provide in a medical home to a patient in a primary care setting. It's about care coordination and care management. And if you can think about 2 things for which you get the most rapid improvement, change, and bang for the buck in terms of clinical quality improvement and cost reduction, it is care coordination and transition to care management. By far, those are the 2 critical things you can start working on even Monday morning and start to make changes that you'll see and feel differences right away. What's transition to care management? Well, we all think immediately about inpatient, outpatient, and that's a biggie. Helping the patient navigate that, making sure that when the patient comes out of the hospital, They see us within 48 hours, 100% of the time, and the information flow from what happened in the hospital happens seamlessly, easily, quickly. You have at your fingertips what you need to know from the hospital care team. How many people in the room are still doing hospital care? Good. Good. Don't ever give it up if you don't want to. Stick with it. Don't ever let anybody mandatorily say you can't do it. But the reality of care in America is, and this happened in my network about 15 years ago, in my group, we started by saying, we have this hospitalist team now available. Voluntarily, who wants to let your patients get cared for by the inpatient team? Let us know. I didn't do it right away. 100% of our primary care doctors did it within 6 months. It is such a profound change in several things. One is quality, because the inpatient team there all day long, instead of me rounding for 20 minutes and not there again until the next day. Lifestyle. It's pretty neat when you're a primary care doc to know you're not going to have to get up at 3 o'clock in the morning and go to the hospital and lose the sleep and be a zombie the next day. When you have an inpatient care team, even though I'm getting the calls about my patients 100% of the time on call when they're in the ER, I'm not going to be the one that has to get up and go admit them. So 6 months in, everybody goes. Eventually it became mandatory because the delivery of quality, the delivery of value is so much better when that setting is done right. But it requires data flow in both directions. So let me give you 2 examples of how important this is and how it fundamentally changes the outcomes that we're talking about with patients. I work in a setting where I'm on the faculty at UCLA Medical Center, but most of my patients get admitted to the local community hospital. It's part of the network of UCLA. Once in a while, my patients get admitted to the mothership, UCLA in Westwood, Ronald Reagan Medical Center, because they go to the ER there, and they're not transferable, and they end up being cared for in this academic medical center. I'm lucky when that happens, if I even know who's taking care of them. And then I'm lucky if I get a discharge summary after they get discharged back to me from the UCLA Medical Center. I get a discharge summary probably in about 4 to 6 weeks by U.S. mail. Useless. Absolutely useless. My local community hospital is not on the same EMR as my group. But when my patients get admitted there and cared for by the care team, we get on my desk, in my fax machine, before the patient leaves the nursing station to go home, I get a templated what happened in the hospital, what happened with the care team in minutes. Not high tech. It would be great if they could push a few buttons and our EMRs talk to each other. They don't yet. So the low-tech solution, I get the fax. It has everything on it I need to know. I have it when the patient comes in, 48 hours, 24 to 48 hours, and it gets scanned into the EMR record. Okay? Vast difference in what happens in the care of the patient. Question for everybody. What % of patients who get readmitted within 30 days in America have never seen their primary care practice before the readmission? And you look at the list of chronic diseases that everybody's target list is, right? Post-MI, stroke, COPD, CHF, pneumonia, you name it. It's abysmal. The answer is it's abysmal. In some settings, in some big cities with some major academic centers that are at the top of the U.S. News and World Report list of best hospitals in America, their 30-day readmission patients, only 20% of them see their primary care practice. They have the worst 30-day readmission rates in the country. There's no care coordination. There's no transition to care management. But transition management also talks about our office to the specialist and back. It also talks about our office to the pharmacy and back, right? Why does that matter? How many of us calculate medication adherence scoring? Anybody? We do it in my group. How do we do it? It's a piece of cake. Why? Because we have an arrangement with the pharmacies in our town that our patients go to. The pharmacies want to do this. Nobody's ever approached them. Think about your community pharmacies and said to them, we went to them and said, you know, we're doing e-prescribing. And when we do e-prescribing, a certain % of our patients say, I don't care where you send it. You pick the pharmacy, doc. Pick the one you like. I can go to any of those chains. They're all covered in my PBM. Now, the pharmacies know that. So when I go to them and say, I'd like you to do something to help me get better care for my patients, they're interested because they want my e-prescription to go to their pharmacy, so when the patient goes to pick it up, the patient buys the toaster oven while they're waiting for the medicine, right? You know how it works. So I got their attention. We go to them, we say, you know, how come we never get information back from you when I send you a prescription? It's always a one-way street, historically. Here's the patient, here's the information on what I want you to give them, and then we never hear back from the pharmacy like, you know, your patient waited 2 weeks to pick up the refill, because they can figure out easily in the pharmacy when the refill was due and the date the patient should have been there, and if it's 2 weeks late, something's gone wrong, they're not taking it right, we need to know. So if you can get that happening, your calculation of medication adherence scores are simple. And we do that with chronic medications. Once you have that, you start to get some really revealing information about, gee, I need to get this patient in proactively. I need to have somebody on my care team talk to them about that transition of care between me and the pharmacy so that they're picking up the med and they're taking it right. Do they understand how to take it? Are they forgetting? Are they getting side effects and not telling me about? How profound is this issue? Well, you all know from experience, chronic medication use, adherence and compliance in America, it's awful. It is awful. How awful? Let's start with pickup rates. How many people are doing e-prescribing? Excellent, outstanding. So here's the good news and the bad news. Mostly bad news. Currently in the United States, this is from PBM data, Pharmacy Benefit Management Company data, national data. What percent of the time when we in primary care write prescriptions for patients for chronic medications do they simply go pick it up? Not even take it correctly, just go pick it up. Anybody know? If you do it on a piece of paper, the old way, they pick it up 64% of the time. That's it. 1/3 of the time, it never gets picked up for 100 different reasons. But you go to e-prescribing. True e-prescribing. Goes to the pharmacy of choice, no waiting, it's ready when they get there. Checks for med-med interactions, checks for allergies, checks for formulary compliance, right? So no managed care hassles. What percent of the time do they pick it up? It drops to 59% of the time. How in the world can that be true if the first item on everybody's list of meaningful use of health information technology is e-prescribing? Oh my God, we made a big mistake. People in Washington fall off their chairs when they hear this. Policymakers. What went wrong? What went wrong is, because this was studied to an attempt to fix it, what went wrong is if you drop e-prescribing into a broken care process in which you don't pay attention to transition management, if you give fragmented care, if the doctor says to the patient, here's a new medicine for your blood pressure, here's a new medicine for your diabetes, go take this, I'll see you in 4 weeks, we'll see how you're doing, and zooms on to the next patient in the volume-based healthcare model, then you get pickup rates of 64 and 59%. But consider this. If somebody on the care team attends to that transition of care management, and the day after a routine office visit for a chronic condition, 100% of the time, somebody on the care team calls the patient proactively the day after a visit and says, in a 30-second script, do you have any questions about the visit yesterday? Did you pick up the medication? Any managed care hassles? Are you getting any side effects? Did you understand what the doctor wanted you to take it for? It takes a minute, less. The pickup rate, if you do that one thing, goes to 92%, paper or electronic. That's the power of doing these things, okay? That and so much more. It's about the whole team, who's on the team, how do we organize the team and communicate. It's about being driven by quality and safety 100% of the time on every patient. How safe is healthcare? It's not safe, folks. So I'm going to get on an airplane tonight, And if you get on a commercial jetliner in America, your risk of dying now is 1 out of every 15 million trips. So every 15 million times somebody takes a trip on a commercial airline, one person dies due to an accident. It's extraordinarily safe. Extraordinarily safe. How safe is healthcare? Well, the best data we have is from hospital care. We think the outpatient care data is worse than what I'm about to tell you. So that's scary. But here's the hospital data from the Institute of Medicine. It's very conservative. It's probably worse than this. How safe is it to get admitted to a hospital? If you get admitted to a hospital in America, your chance of dying due to a mishap, not your disease, is 1 out of every 15,000 admissions. 1 in 15 million, 1 in 15,000. Okay? We have a big problem. My own institution, UCLA, the Mecca of medical care based on U.S. News and World Report, right? Top of the list of great hospitals in America. I chaired the Quality and Safety Council for a number of years. And we'd have quarterly meetings where we'd have department heads get up and report their data on quality and safety. And it would go like this. The radiology department would stand up and he'd say, we had a good quarter. 90% of our patients got to their x-ray and back to their bed without falling out of the gurney. Great, 90%, good, sit down. Next department. Why was that okay? Because a lot of you know that the Joint Commission that accredits those hospitals would say to the hospital, if you hit 90% on these metrics or better, you pass. One day, in one of those quality council meetings, the sitting president of the American Medical Association, who's a cardiovascular surgeon in Santa Monica, he stands up. He says, that's it, I've had it. We're not doing this anymore. This is healthcare, this is people's lives. It has to be 100%. Would anybody in this room be happy if that airplane you got on landed safely 9 out of 10 times? Would you be happy if 9 out of 10 times when you turned the key, your car started? That's okay, 90%. Would you be happy if your telephone worked 9 out of 10 times? Right? I don't know, with Verizon sometimes I would be happy. You see the point? Quality and safety, 100% of the time, every single patient, driving force. It's about using technology to its fullest. That's one of the principles here. It is e-prescribing. It is clinical decision support. It is population and disease management. And a whole bunch of other things. It's not electronic paper. And when we make that shift to true technology use, the right way, magical things happen. Another example from real life. My own personal family physician, who was not in a medical home when I started to see him, had the world's record, because I worked in the same network as him, I knew this, of having paper charts. We were on paper. He had the world's record for having charts stacked up in his office. If anybody on the staff in that clinical setting needed to find a chart, they would start with his office, whether it was his patient or not. Always. An average number of charts that he had stacked up waiting for action. This stack is for callbacks, phone calls. This stack is for refills. This stack is for paperwork, and so forth and so on, right? Average was 65 charts stacked along the wall. Mondays, I don't even want to tell you how bad it was. His practice setting moved physically to another part of Los Angeles. I still go see him. So I go to see him for a physical. And now we're all on EMR. But his setting was doing just electronic paper. And if you asked him when he switched to EMR, how do you like your computer? His answer always was, it'll be the death of me. But the reason it will be the death of him was because when I went to see him for the physical and I got done, he said, go sit in my office. I have to go do something. I'll be in there in a few minutes. We'll talk. I sit down in his office room, and I'm looking around, and it didn't hit me that he was on complete electronics, and I don't see the 65 charts stacked up. And his nurse notices the look on my face, and she knew exactly what I was thinking. Wow, this is pretty cool. She walked in and she said to me, you don't understand. takes me over to his workstation by his desk, his electronic workstation, pushes the button, and brings up the 65 charts. It's an electronic queue that he's waiting to take action on. He just made electronic paper. He hated it. He got home late every night. Worse than when he was on paper. Now we're 5 years out. Now if you say to him, how do you like your EMR? He will defend to the death using that EMR. If you try to take that away from him, he will not let you do that. It is essential because they went past the electronic paper and truly used the technology. And the last element up there, which is critically important, is practice management. We are all in a small business. Even if we're in a big medical group, it's still a small business compared to those companies out there that have hundreds of thousands of employees and spend billions on healthcare, literally billions. We're a small business. We have to run it efficiently, do it well, have a great bottom line, and make it sustainable. What did we learn? Well, we learned all of these bullet points and are still learning in this research project on medical home about the importance of these issues and how well or not so well we're doing it. And when we look at it, we have some problems. We have a problem with access. If we organize our practice around what the physicians need, we're not going to get the job done. Greatest example I could tell you comes out of Albany, New York, and how this was so critical in the fundamentals of medical home movement because in Albany, New York, there happens to be something called the Capital District Physicians Health Plan, founded by physicians, a health plan founded by physicians that are now on their third generation of medical home. Big success, great outcomes, lowered cost of care, patients love it, everybody's winning. It's taken a number of years to get there. One of the people who started CDPHP was a family doc in a 10-doctor practice in Latham, New York, a suburb of Albany. His name is Bruce Bagley. Some of you in the room know Bruce. I know you know Bruce. Bruce is an incredible, forward, key opinion leader and thinker in the medical home movement. Bruce was president and chair of the board of our academy, family medicine. And he decided, after being in that practice in Albany, New York for about 25 years, went through the leadership track of our academy, to transition out of practice to a national position at the Academy. He is the Director of Quality Improvement for the United States of America Primary Care. He is the czar of quality improvement in primary care. So Bruce is a great guy, and he openly tells this great story about his own practice to illustrate the importance of access, the importance of what we do in our organization, our practice, that's not around the patient, but around us. And the story goes like this. He heard every single day what I hear from patients all the time. Well, you will hear. Dr. Fromer, you are harder to get on the phone than the President of the United States. I can't tell you how many times I've heard that, right? We build protection for the doctors so we can get the job done with the patients, and we make it hard for patients to get in through to us and communicate and all this. Well, Bruce used to hear that every day. His doctors heard it. They knew they had a problem with the phones. And he tells a story that the 10 doctors sat down and said, we got to fix this. It's killing us. The patients hate it. How do we fix the phone system? So the 10 doctors sit down and they decide, we need more phone operators. That's the problem. There's a bottleneck. They hired 3 more phone operators at great expense. 6 months later, nothing was better. They sit down again, the 10 doctors, and they say, we need a phone computer. And they spend $250,000 buying a phone computer, whiz-bang phone computer, does everything for them, produces reports on how many calls before they pick it up, how many rings rather, how long the patient waits on hold, who hangs up, sequences all the calls, and 6 months later, nothing is better. The doctors meet again. The problem is, they're all trying to do everything in that whiz-bang computer and that extra bank of phone operators in the main entrance to our main office where there's all kinds of noise and chaos and managed care happening, and it's crazy and they're getting interrupted. We need to move them down into a basement next door that's real quiet. And at great expense, they move them and they move all the phone trunk lines, and 6 months later, nothing is better. One day, 18 months into it, $500,000 in real and indirect and direct costs. Bruce Bagley, Dr. Bagley, he's seeing patients. Nothing's been improved in the phone access. And one of the phone operators approaches him and says to him, Dr. Bagley, the phone operators got together, we had a meeting, and we think we figured out what's wrong with the phone system. What a revelation. The people who actually do it, giving input to how to fix it. That was the first thing he loves to tell a story about, the importance of that. Everybody in this room participating and getting things better. Team-based collaborative care. She said, Dr. Bagley, I want to share with you what we decided, but you got to promise me something first. He said, what is it? She said, you got to promise me you won't shoot the messenger. He said, okay, what is it? And she said to him, Dr. Bagley, we figured out the problem. The problem is you. What? She said, the problem is all you doctors. Every one of you have given us a booklet on how to schedule your appointments. And you've told us in these instructions on what we have to go through when a patient calls and says, I need to come in to see him for a pap smear, and I have this thing on my arm that I want him to look at, and, oh, I hurt my ankle, then schedule it this way. But if they say the same thing and the moon is full, then schedule it that way. It takes us 15 minutes just to figure out how to schedule a routine appointment for each one of you, and that's what's backing everything else behind it. They made a great case. Doctors agreed. And what did they do? Every book got thrown out. No one was allowed to give instructions to the operators about how to schedule anybody's appointments. No one. They went to a long and a short appointment. This list goes in long appointments. This goes in short appointments. We're done. It's simple. What happened? It got so easy to schedule appointments that the patients now do it themselves in his practice if they choose to, through the internet or through a touch-tone phone, just like in my practice. They can still call an operator if they want, but they don't have to. They then lowered, by doing that, the cost of each appointment from about $1.80, direct and indirect cost, to about 2 cents. So the practice thrives financially with that. Lowered overhead, right? Patients love it. No block to access through the phone, and on and on and on. Okay? He loves to tell that story. It's so important. Working down the backlog. There's something called advanced access that you'll hear about in the elements of the medical home. It's a revolutionary revelation. 10,000 places that are doing advanced access, the science of how you give patients exactly what they want and what they need. What do they need? Right diagnosis and right treatment. What do they want? Access, access, access. By the way, in my office, I truly did hear that same thing all the time. You're harder to get than the President of the United States until we fixed the problem. I came out of the exam room one day in the 1990s when Health Reform 1 was happening, Mrs. Clinton. I came out of the exam room, and on my desk was one of those notes from my receptionist. You missed the phone call note, right? And it says, Mrs. Clinton, the White House, and a phone number. And I went over to my receptionist. It's a true story. I was president of my state chapter at the time. I went over to my receptionist, and I said, what's this? She said, Mrs. Clinton needs to talk to you. The White House called. She's got to testify in Sacramento tomorrow, and she needs to talk to you. I said, why didn't you get me out of the exam room? She said, Dr. Frommer, you gave me specific instructions. Do not interrupt you unless it's the hospital, a doctor, or your wife. She was right. I had given her those instructions. We need to move past that kind of organizational structure in the practice. What do we know about practice-level services? We're losing that basket of services we got trained to do. Over the years, it's eroded. We have to get it back. We have to do this great, comprehensive basket of services that we can do and provide for patients inside the primary care medical home of the patient. Well, that Wagner chronic care model and the AMA data and various other places have proven to us that if we can manage care, we can coordinate care, we can get great things done. And I'm sorry I keep telling you about my own experience, but I think it's so illustrative, and I think the stories really do anecdotally add this great footnote to the science we're talking about of improving. And I want to share with you real quickly another story about one of my own patients and how important care management and coordination is. and how it fundamentally can change the quality and outcome and experience for the patient. Again, UCLA Medical Center, the mecca of medical care. It's gigantic. It's huge. The buildings of the Ronald Reagan Medical Center at UCLA, the hospital and the outpatient buildings, contiguous square footage, second largest building in the world. That's how big it is. The Pentagon is number 1. This is number 2, total square footage. My patient, brand new patient, comes in to see me, picked me as her primary care provider on her health plan, walks in with a paper record stack of historical chart this high, plops it down, first visit, and says, "You got to help me. 10 years I've had pain in my arm. Nobody's figured it out. They can't feel. I've had everything done. You got to figure it out, doc." So I did what we're trained to do. You know, anything urgent happening? No. Met each other, learned about each other. I said, "Give me time to go through the records. Let me check with some people when I go through the records about things I might need to ask, and then I'll see you back in 2 weeks." Comes back in 2 weeks. I had gone through the records. I had curbside some specialists and opinions. What do I do? And we all decided the only thing she had never had done to figure out why she had this chronic pain in her arm, everything else had been negative, $1 million workup. No one had ever looked at the blood flow to her brachial plexus, the complex of nerves underneath the arm and the axilla here that kind of controls all of the nerve connections out into the arm. No one ever looked to see if she had some bizarre reason why she had a blood flow problem to that. So we all decided she needed an MRA of her brachial plexus. That's an MRI where you also give contrast material so you can look at anatomy and blood flow at the same time, right? There's only 2 doctors in Los Angeles who do that, and they're both at UCLA. So I dutifully get her approval on the health plan, all her utilization, got it done. The team I work with gets it approved by the health plan. We give her the form with the phone number. She calls the computer scheduling module at UCLA to make the appointment. And she called on March 1st of the year this happened. And the very cheery person, customer service rep at the computer scheduling center for UCLA, said to her on March 1st, "Oh, yes, we have an opening for you to get this test done on December 10th. And she said, "Wait, no, there's got to be a mistake. Wait a minute. This is March 1st. You're giving me an appointment 9 months from now?" "Yes, well, one of the doctors of the 2 who reads these, the only 2 who do this, he's on sabbatical. So we only have half the capacity, and there's a big backlog." She got so angry, she slammed down the phone, picked it up, called me, and said, "Fix it," and slammed down the phone on me. I called the doctor who's still reading them, the one of the 2 people who's still doing it. I told him the story, and he started to laugh. I said, "What's so funny?" He said, "This happens up here all the time." I said, "What happens?" He said, "Well, you know, my partner is on sabbatical, and I have to do all the readings. So as soon as he went on sabbatical, they took away all of my research activity, and they took away all of my teaching, and all I'm doing is this, clinical work and the readings. So I doubled my capacity to do it, but nobody ever reprogrammed the computer system for the scheduling. So they don't know that I have all that extra time." So I'm talking to him on a Monday, and he says, "I got 10 openings on Wednesday. Can she come in?" Care coordination, care transition management, help the patient navigate. You get tremendous impact in what happens. Tremendous impact. Don't forget about community resources to help the patient outside of what we do. The sickest of the sickest patients with multiple chronic conditions, the ones we all think about every day, those people, those folks, they are, even them, living 90% of their lives outside the health system, not with us. It's critically important to remember that. Care teams. When you have care teams, you have a struggle to communicate. How many channels of communication are there when you have 2 people on a care team? There's 1 channel, 2 people. How many are there when you have 5 people? There's actually 10 channels of communication. You'll see the formula as we delve into this in a few minutes. But that creates the potential for a challenge to getting the job done. Internal and external communication, just critically important. Team-based care is vastly different than the model we have now. You need task grids. Who's doing what on the team? Training so people can do the task that's in that checklist of what they need to do. All of that matters greatly to change this footprint of how it looks. We don't have practices being driven by quality and safety now. The outpatient data, the limited amount we have compared to that scary hospital information about safety, it's even worse outpatient. Too much variability, too many excursions, therapeutic misadventures, diagnostic misadventures. We have to get that to stop. We don't have adequate safety now in our clinical processes, in our workflow processes. If it's built into what we do, so it's easy to do the right thing right every time, all the time, rather than heavy lifting, that's when you have a medical home. That's what these principles are about. It's about making it fail-safe in how we organize the framework of the practice so the culture of quality and safety is easy and done every day, all the time. Big problem with HIT. We can't just have electronic paper. What we learned, we're not using technology to its fullest. We're not doing clinical decision support. The best we have with technology and CDS is we have reminders pop up on screens, right? Oh, this patient should get an immunization because the computer has figured out, based on their age, based on their problem list, based on their encounter data, that they're due for a pneumovax. You know what's happening with reminders? Interesting study done out of Australia and New Zealand, worldwide study, including the United States. Reminders that pop up on the screen are not only useless, they actually are counterproductive, because if you don't do it right, what happens is the clinical teams getting those reminders hate them. They get in the way of what you're trying to see behind them, and people turn off the reminders. Big problem. So, snapshot. Google, search engine. Regular old Google search engine that we all use every day. Give Google search engine signs and symptoms. How often does it get the diagnosis right? This study was also done. Big international study. Just tell Google what the patient's signs and symptoms are. How often does it get the diagnosis correct? Turns out to be 68% of the time right now with the knowledge of the Google search engine. Logical question. Give primary care doctors signs and symptoms and nothing else. How often do we get the diagnosis right? Turns out it's 70% of the time. There's only a 2% spread. The leaders of Google have said that what they are engaged in doing is making that search engine smarter and smarter and smarter. They want to be playing in health technology. They predict that with their algorithms getting better and their database getting better with what people are searching on, they have this way to, you know the story about they were quicker to know when flu epidemics by zip code would happen because how people searched in their engine told them whether they were sick and where their IP address was, that they were able to produce maps of the incidence and prevalence of flu literally day by day, faster than the CDC was able to do it. Same idea. As they build this database and the algorithm better and better, what happens? They predict that their clinical decision engine, by signs and symptoms, will make the diagnosis right about 90% of the time within 5 years. Does that put us out of business? Never, ever. I want that to happen. I want to be able to have some system take the information and help me make the right diagnosis. That system will never be able to do what we all do. But Einstein said, I don't ever want to memorize something I can look up. And he said that 80 years ago. Why in the world do we want to memorize what we can look up? But what I do want is automated support and technology to help me get the job done. The job we have to do is make the right diagnosis. We have to give them great access, all the things we've been talking about that technology can happen with us. Organizing the practice and how we do it, lots of gaps here that can be made better. As we become medical homes, as we do this, there's so much opportunity here to make more efficient what we do and how we do it. And I have to tell you, there is data that even in the No change in the payment environment right now. If you become more efficient, you lower that overhead like Dr. Bagleys' practice did with having patients do their own appointments. And by the way, that's why we all buy our own tickets on the internet for our plane travel now, because you save the airline a fortune when you do that. Drops the overhead dramatically, right? When you organize the practice and the small business that you're all engaged in and do this well, you'll see your finances take off. Add to that alternative payment methodology, and you've got a gigantic win. Patients, what's going on that side? Somebody threw a party. The party was called Patient-Centered Medical Home, and we forgot to invite the patients. The New York Times actually uncovered this faster than anybody else. They ran a series on this revolution in healthcare. Did anybody tell the patients what it was about? And it turned out we didn't. We forgot. So we have to go back and make sure the patient's literacy and health literacy improves, that they understand this process. They don't like e-visits, but we're trying to kind of do e-visits. They will like e-visits. They work if we do it right. And the patient has a buy-in incentive. Carrots work better than sticks. I always think rewards work better than punishment. We do it right. We've got models and examples where if you engage the patient and reward them, they love these things. In my system, because we already accept global payment based on outcome, we get a bonus. When my diabetics are compliant and adherent to 90% or higher of what we ask them to do, we reward them. We give them a free health club membership for a year. It costs about $180, $200. We negotiate a better rate from a really nice health club. Why do we do that? That's never in the health benefit. Blue Cross doesn't give that as a benefit yet, right? Only selectively. All right, some do. Good. That's good news. Why would you want to put that in the benefit? Well, we had a no-brainer when we did it because we analyzed it and said if we give that to patients and that helps engage them to live healthier, and we get rewarded when they get a better outcome because they're living healthier, more of them get to their A1C goals on diabetes, they get to their blood pressure goals, they get to their lipid goals, they lose weight, I'll pay the $180 because I'm going to get rewarded $500 to get that target result. We do the same thing with asthmatics to engage them. You know, go right down the list. It frees you up to do a lot of these things to engage the patient when the methodology of pay recognizes delivering value, which includes patient engagement. We can do this. Everything fits together that you're going to hear from myself and the subsequent speakers. These are pieces of a puzzle that fit together. The model works. It's been proven by research. This is not about doing things and checking boxes. That's how you get the NCQA recognition. That's what you're going to learn today. But that is your roadmap to change the culture in the practice every day so you live, eat, and breathe these principles. And the patients do great. How about the finances? Critically important thing to recognize. That after the first very short amount of time going through the change chaos, that even if you didn't get alternative payment supplements and just continued to do fee-for-service in the current RBRVS environment only, something that's not going to be true, but let's assume it was, I propose to you that very quickly, if not already, you're getting alternative additional payments. Even if you just did that, look what happens. Because of the efficiencies and improvement in workflow processes and success of all of that, you get a better bottom line in your practice and you get a better take-home result net after you subtracted the overhead. It's from the efficiencies and improvement and throughput improvement. It's just that first little, 4 to 6 to 8 weeks of, hey, this is chaos, this is change, how am I going to deal with it? Clinical metrics skyrocket in many ways. Measure it, report it, show it over time. Everything gets better, not just the finances. What are the success factors? And then we'll finish up. There they are. To make those elements of the medical home true and happening, starting Monday, as you start this journey towards this, you've got to have great teamwork, You've got to have leadership through the change, and you've got to communicate well because teams have to talk. We learned that teamwork is not an inborn skill. It is tough. It is hard to make it work right. Sometimes that happens. In healthcare, that happens a lot. The core competencies that make teamwork successful start with trust. We have to trust each other. The patient is a member of the team, remember. Patient-centered. Patient is a core member of the team. We have to trust each other. We have to build trust. The patient has to trust us. We've got to manage conflict between members of the team, right? These dynamics. Everybody's got to be on the same page. We've got to know what our task is. That's a task grid. That's that checklist. We've got to be accountable and own it. And we've got to have follow-through. We can't say on Monday, this is what we're doing, and then forget it. Every day this has to be worked on. Every day. But the payoff is huge. We've got to manage change. And what we learned was we hate change. We're not ready for change. Primary care especially. There are only two kinds of people who love change. Consultants and wet babies. That's it. The rest of us hate change. Doctors particularly hate change. We have like 100 reasons. Bring me another paperclip and I'll kill you. We're running so fast on the hamster wheel, the last thing we want to see is change. But we've got to break that conundrum. We have to be able to get out of that narrow vision of saying, this is the way I've always done it, and this is the way I'm going to do it. And I made it work. Yes, you might have made it work now with a lot of heavy lifting, tremendous amount of hard work, and more every day, it's tougher to get the job done. Change is about new paradigm. Change is about culture change. We have to be motivated. That's happening with the recognition. That's happening with alternative payment. That's happening with this move to accountable care. Sometimes you can harm the practice if you don't buy in completely. That's what we learned. So you can't put your toe in the water and step back. You've got to jump in the pool. And jumping in the pool is scary, but the reward is an Olympic gold medal. Because if you do medical home, you'll get to that finish line, and that journey will be enjoyable. Chaos is going to be there. This is known. This is normal. We know this from the science of process engineering. It's going to happen. Leadership through that, faith that at the end of that process you're going to take off. Time goes forward. The new status quo on the right there is in a much better place. So the journey is going to follow that pattern. If you're aware of it, you're ready for it. Leadership is a big issue. Everybody in this room is a leader through this process. Everybody. We have to step up to the plate, and we have to lead through this transition. It generates fear, there's no question about it. But in the practices that have done it, the leadership steps forward, it happens, the practice comes out the other side, the patients love it, the patients lead themselves through this change. You will see amazing, beautiful, wonderful things happen. Communication is so critical. Internal and external. In the practice team, with the patient, and external to the community. It gets really complicated as you put more people on the care team. Very complicated. The formula, which I alluded to earlier, is you take the number of people on the team, you multiply that by that number minus 1, and divide by 2. That's how many channels of communication you have. So if you have 10 people on a care team, always include the patient, it's 10 times 9 divided by 2, 45 channels of communication. Potential. If you're not all working off a dashboard of information that's the same on what's going on with the patient, we got a problem. So you got to work to make that happen all the time. If we don't, that complexity is really going to undermine the process. So we have these pilots that were done. We looked at all the stakeholders and all the systems. If you do pay for performance already, that's not a medical home. If you do chronic disease management and nothing else, that's not a medical home. Those are pieces of elements in the medical home. This is about putting all those pieces together. It's about everything operating on 8 cylinders. What about payment? Alignment to reward for delivering medical home style value-based care is critical. Ira said it, you're going to hear it all day. You've got to have this along with it, otherwise we can't be sustainable and successful. The various ways to reward us, in addition to fee-for-service, the traditional current model, are up there. There's 17 different ways now to do this, and every day or every week we see more coming on board. There's your list. Fundamental in all of it is that it recognizes that volume has to move to value. And in order to do that, we've got to measure the delivery of value and prove it. And that's report cards, and that's metrics that we agree on, and that's runtime analysis in those metrics to see if we're hitting those targets. A little snapshot of global or bundled payments, because it's one of the more popular ones. You see up there and how this happens between hospital and us, right? Episodes of care, as an example. Why transition to care management becomes so critically important. I like shared savings models. I think they're wonderful. I really think they're great. Deliver quality, prove you've done it, thereby save the money, share it with the people who generated that. And I will share with you that when we did a national survey on diabetes a couple of years ago, and we asked programs, we asked big systems, little systems, individual practices all around the country, are you in any contracts to get rewarded when you deliver quality and it comes in at a lower cost? I could tell you 100% of the time that when the answer to that question was, yes, we are, and then you said, how are you doing on your quality metrics in that disease state for which you get rewarded? 100% of the time, if they said they had a contract to get rewarded for that, they were in the top 10% of performance metrics in the country for that disease state, those practices. 100% of the time, if they answered that first question with, you know, we've been thinking about that, but we don't have those contracts yet, but we think it would be a good idea. And then you looked at their quality metrics, their performance metrics, they were either average or below average. It was uncanny how it was 100%. I don't remember one participant in the survey, and there were hundreds of sites across all demographics and across all size. You gotta have alignment of financial incentives to deliver the right thing, patient-centered, value-driven care. So think of this as a medical neighborhood, that we're a part of that neighborhood, and our medical home is a fundamental part of that neighborhood. You may not want to call it a PCMH. Don't get stuck on the terminology. I know a lot of people, you say to them something about a patient-centered medical home, and they say, what is that? Is that something that's halfway between the nursing home and the funeral home? The name is less important than the function. It's a high-performing primary care practice. That's what we're talking about. The neighborhood is a system made up of those high-performing practices. So you can see how this is fundamental as the basis for an accountable care process. What's in the medical neighborhood? Look at those elements. What we want to deliver to a community of care that we give and improve the outcomes of people in that community. The result, the things we want. Higher quality, focus on chronic illness. How big a problem is that in our system, by the way? You know we spent $3 trillion on healthcare last year, right? $3 trillion. How big is that number? Well, let's talk about how big 1 trillion is. I always had trouble kind of envisioning how big is a trillion. Till about a month ago. A woman who writes a healthcare blog talked about this in her blog, wrote about it. And she had a great example which really framed it for me the best I've ever heard it. Go back to the beginning of the calendar we used 2011 years ago. Day 1 of the Roman calendar. Day 1, right? Imagine that somebody started to give you on day 1, 2011 years ago, $1 million every single day. Right? Imagine if you got $1 million every single day for the last 2,011 years. So you multiply 1 million times 365 times 2011. You still would not be close to $1 trillion. That's how big it is. We spent 3 of those last year on healthcare, Our federal government owes 16 of those. Okay? Big number. Question is, what percent of it do we spend on chronic disease management, wellness, and prevention, and what percent of it do we spend on rescuing sick people? In every other health system in the world that we get compared to, they spend about 50% on each. You know what we do? Of the $3 trillion, give or take, what we spent last year, we spend 90% of it on rescuing sick people. Only 10% on chronic management, wellness, and prevention. We are talking about a fundamental paradigm shift in that number. Medical home is about keeping people with chronic illness well, avoiding exacerbations, avoiding meltdowns, avoiding hospitalizations by keeping them well. The medical home looks like this. Ira put up his version of this. There's my version of it. It's California style, I guess, different shape of the house. Same idea. Fundamentals, you hang on it. There's continuous healing relationship over time that's comprehensive. You live a culture of quality improvement. We do it with great access, personalized care, focus on care coordination, use your technology to its fullest to communicate well, to be on the same page with the patient, manage it perfectly, and you've got a medical home. And what happens with that roof that's called great outcomes? We used to focus on that and say, that's about the patient. And it is, first and foremost, a great outcome for the patient. But you know what? Now we know it's also a great outcome for every one of us. To live through doing that, we get a great outcome, which translates into a great outcome for the community we serve by being a practice in that setting. And that's the beauty of that model. So let's finish by making it real, and let's talk about this patient pathway of care. If the patient's at the center of this, and we're talking about a journey, let's look at that journey of the patient care process. And here we are. We're back to Ed Wagner's model of the chronic care paradigm. Informed, activated patient. Fire's been lit under them. We've motivated them. They're taking care of themselves with our help. We go from compliance, which was we say they do, to adherence, which is together let's make a decision, now go do it, to concordance. How many people heard the term concordance? What's concordance? It comes out of the British health system, one of their policy people there, and he said concordance is making decisions with patients based on science that are concordant with the patient's life they live outside of our health system. The reality of where they live, they work, they play, they go to school, right? If you're not concordant with their religious beliefs, their family support, their social structure, right, their financial issues, if we can't take that into account and we're not concordant, we won't get great adherence. That's what this is about. Our care team's doing it so we get great outcomes, and there's your journey. Left to right, that's a timeline. It's a template all about touch points with the patient in a medical home model that's way beyond face-to-face visits. It's all about asynchronous communication. It's all about fax and email and patient portals and outbound phone calls about picking up your medicine and raising your health literacy and so forth. Here's what it looks like with a clinical bent on it. And the foundational pillars that you see here, coordinated team care, empowerment of the patient so they're active, not passive, raising their health literacy, managing the population of people with a disease state, and using your technology to do it is what we've been talking about. And on the timeline you see in your handout, that's tough to read, I know. Don't worry about reading the little print. In those boxes, those color-coded boxes, we talk about the journey through care in a specific disease state. There's one of these for each chronic disease. And what do we do at each step? The members of the care team, what dashboard of information do we need like that to take care of patients? This one happens to be on a diabetic. You can't drive home today without a dashboard telling you how fast you're going and how much fuel you have and all that. You can't manage patients without a dashboard. And if we all on the care team have the same dashboard, then we're working on the same page and we know what we're supposed to be doing and we're tracking it over time. All of it gets loaded into the technology we use. And don't despair if you don't have an EMR yet. And don't despair if you have a big EMR and you're not happy with it. Because the great news is, in the world of HIT, what's happening is We just demonstrated this at the table this morning as Ira and I were going through a few things. The world is changing so that the $250,000 enterprise-wide EMR that cost a lot of money and a lot to update and keep current is turning into a core on which we hang very inexpensive applications that run on a smartphone or an iPad, right, or an Android device. And those applications do things that interact and interoperate with the EMR easily. And they do things like registry and task grids and patient portals and so forth. So let me finish by telling you, a few weeks ago I was in Erie, Pennsylvania, presenting Medical Home to the Primary Care Network. They were doing their annual primary care update. And every single doctor in the audience, a couple of hundred doctors, had an iPad, which I thought was kind of strange and interesting. And they were all doing things as I was working. We were going through the presentations. And at the break, I went up to the Chief Information Technology Officer, who happens to be a family doctor, and I said to Sam Reynolds, "What's going on? How come everybody has an iPad, and what are you guys doing with it?" He said, "Well, in this community, the two hospital systems here got approval legally to give the iPads to the doctor networks that work with them, that were in the audience, the iPads. The hospitals paid for them. And we are all using them with apps that we get to do these functions for our patients." I said, "Well, what apps do you have?" He starts to show me what he's doing in his practice with his patients. He shows me his registry app. He said, "That's pretty cool." He shows me his task list app. That's pretty cool. The dashboard app. That's pretty cool. I said, "How much do these things cost?" He said, "Oh, most of them are like $1.99. They're scalable up to any size practice." And then he said, "But the registry app was a lot of money." I said, "Well, how much was that?" He said, $9.99. That's the future we're heading into, to have technology help us. Right there in the exam room, real-time clinical decision support, get the job done. Task grid, down the left, who's on the team, across the top, what has to get done, disease by disease. Dr. Gawande wrote something called the Checklist Manifesto. How we can improve healthcare with simple checklists for a variety of things, hundreds of things. Here's a task grid checklist. Who's on your care team, specific for your practice, and what does everybody have to do in a disease state to get the job done? Fundamental paradigm-shifting implementation of the medical home. Simple to do starting Monday. Start to think about what tasks have to get done in this team-based grid that's different than we used to do. Who's going to call the patient the day after a visit and make sure they picked up the medicine, and do they have questions on how to take it? Very important paradigm-shifting change. So the evolution of expectations have changed. This is what people are expecting of us in the system to be an integral, foundational part of delivering accountable care. Clinical integration, great science becoming great care. The bottom line is value. That's what they want. That's what our country needs, the patients need, everybody wants. If you can do that and deliver that, you win. And that's what the medical home can do. We all have to lead through that. Every person in this room, just like the operators in Bruce Bagleys' practice, who led the charge to figure out what was wrong with phone access. Not the doctors leading all the time, and only the doctors. Yes, we are the captain of the team, but the champion of every disease state in my office is never the doctor. Never. I am never the champion of asthma care. The champion of asthma care in my office on the care team happens to be my medical assistant, because she has asthma. The champion of diabetes is a person who works at my front desk, because both of her parents have type 2 diabetes. She can be more concordant with the reality of a diabetic's life in the community than I ever could. I'm the captain of that team, clinically, but she champions our efforts in that team to get the job done in our medical home model. Critical issue. I'll finish with this. Everybody who we take care of deserves a medical home. Every American deserves it, and that's why we're here today, and that's why Florida is going to be changed for the better when you do it, and you are going to start down this journey right now. So I'm going to say thank you.